Thanks so much for that kind introduction, and thanks to the organizing committee, and especially Sean Mooney for inviting me. Boy, what a fabulous talk and a hard act to follow now. I went from Alexandria to Newton to Boston Dynamics. This is going to seem mundane, unfortunately, but bear with me. So we're supported by NIH and NIAMS specifically. So I want to acknowledge our P30 grant and disclosures that I have. So a wise man said pretty recently that AI tools have the potential to help make clinicians' job easier. And so I think Sean asked me to come to speak to you from the perspective of a clinician researcher, really. And hang on one second, I'm going to switch my glasses here because I'm always wearing the wrong glasses. So I'm going to be talking about this CLEAR Center that Dushyant mentioned I'm the director of, and it's funded by NIAMS, so it's focused on musculoskeletal disease. I'm going to talk a little bit about who we are, what's our goal, and what we do, and hopefully this will stimulate potential collaborations, since you've heard today that that's important. So who we are, so one of the things I probably would have done is picked a different name for the CLEAR Center. So we're not the people at the airport, and we're not at UC Davis, and we're not saving you money. So we are here at UW, and we're really focused on clinical trials, clinical research in the musculoskeletal space. We have a number of partners, and we've got 3 cores. So we're University of Washington School of Medicine, we're the School of Public Health, and multiple departments within each of those schools, and also the University of Utah. We're collaborating closely with for access to CMS data. And one of the things you've already heard this morning is how important collaboration is. And you know, one of the reasons I think the University of Washington is such a great place to be is because people's doors are open. It's easy to collaborate here, certainly compared to other places, and it's key to success. So our funding is for infrastructure, not individual projects. Here's the leadership. So along with Jana Friedley, who is in the Department of Rehab Medicine, we direct together the administrative core. Patrick Hagerty in biostats and Sean Mooney help direct our methodology core. And then Pradeep Surya and Sean Rundle direct our resource core. And I'll be talking about each of these a little bit. So, you know, first of all, and recently we added 2 patient stakeholders, since the patient's perspective, of course, is key to helping direct what are really useful areas that our center should focus on. So what's our goal? Our overall goal is translating clinical data for musculoskeletal care into research-ready data. And so obviously there's the fit with the symposium today. We have a number of approaches to this. So one way of taking clinical data and making it research ready is to embed clinical trials within the clinical infrastructure. And so we have a group that's focused on clinical studies designs, and especially pragmatic designs that take place within the healthcare systems. And then groups focused on EMR and then conducting actual clinical trials. So, as I said already, new approaches to study design and especially pragmatic trials. We have design studios where we invite investigators from outside our center to come and present ideas to us, where we can then help them develop those ideas and bring them to maturity. And we are fortunate in that we've got multiple groups that can give input to these investigators, so informatics and biostats and operationals and other key stakeholder groups. We are also interested in developing new methods and especially pipelines for analyzing the clinical data, both within UW as well as external to UW. So extracting data from free text radiology supports. I'm a radiologist. A lot of the data that we've collected is imaging centric. So using NLP to extract some of that data. And then, of course, machine and deep learning approaches for getting data directly from the images themselves. On the NLP side, over the years, we've had graduate students and junior faculty that have worked with us to help develop our ability to extract these concepts from imaging reports. Unfortunately, many have flown the coop to greater success and fame. Here are some of the papers that we have put out, again, focused on spine and musculoskeletal conditions. And here's a list of the findings that we're actually extracting from reports. And we can do this on a number of different data sets now that we've accumulated over the years. We're also very interested in processing images directly to build predictive models of various sorts. And sort of a use case that we focused on is an opportunistic identification of osteoporosis. So using existing data within the healthcare system, and we're focusing on plain films of the spine, to identify people who potentially have osteoporosis but are unaware of it. Why use osteoporosis as a use case? Well, I think it's essentially taking advantage of a favorable situation. So here's a picture of the Mariners with the bases loaded. You don't want to not get at least one run in this situation, right? The odds are stacked in your favor here, and so they are, I think, with osteoporosis. So first of all, there's strong evidence out there already that screening for osteoporosis leads to better outcomes. It has a grade B rating by the USPSTF and is mandatorily covered by insurance because of that. So strong evidence that it's a good thing to do. Secondly, there's gross underscreening currently for osteoporosis. Probably only about 20% of those eligible for screening are actually getting screened. And so there's a real gap in clinical care. Spine fractures are a great biomarker for osteoporosis. So you don't necessarily have to measure someone's bone mineral density to say they have osteoporosis. If you have an osteoporotic compression fracture, that's a better predictor of subsequent hip fracture than a bone density score is just by itself. So it's a good biomarker. And spine fractures, while they exist within the medical record, are frequently underreported. Now, radiologists are busy people. We're going through hundreds of films, potentially over the course of hours. And we're focused on solving clinical problems usually. If someone gets a chest x-ray for pneumonia or trying to figure out where a particular line is, they're not necessarily focused on identifying that long-standing, potentially incidental osteoporotic fracture in the thoracic spine. And so they're not appearing in the radiology reports as frequently as they should. So our goal was to really use existing data to address this clinically important problem. We started with UW images and trained a network to identify these fractures on plain films, and then have other data sets available that we can look at the generalizability of this. This group is led by one of our junior faculty, maybe not so junior anymore, Nathan Cross in radiology. And we have a number of other faculty as well as students, grad students, medical students. In fact, one of the medical students, John Renslow, is here in the audience. He came up from USC. He's been working remotely with our group and doing a fabulous job, so thank you, John. We've got a number of resources available for this sorts of work and other work, actually, again, as long as it's in the musculoskeletal space. We have a number of partners. Henry Ford, who has been a clinical site for a number of different studies that we've done, has contributed imaging studies that we have, mostly X-ray, several thousand MRs, you can see in some CT. We have abstracted the radiology reports. We also have complete EMR data as well as billing data. From UW Medicine, we've got X-rays, identified patients who have osteoporotic fractures, and again, we have the EMR data and clinical reports. And then we've got partners from a couple of longitudinal observational studies of osteoporosis. There's the study of osteoporotic fractures, which is a longitudinal study of women, and then the Mr. Oss study, which is a complementary study in men, both of which have been going on for decades now. We've got several thousand images from each of those as well. So we have a number of different data sets to both build and then test and validate the models that we have. And this is sort of the overall goal, is to build this pipeline so that an image gets taken for a clinical reason. We can then automatically do QA and normalization on those images. We can identify then each vertebral body and then apply our fracture classifier to that vertebral body, then build a summary of a report of those findings, combine it with different types of data, multimodal data, if you will, from both the DICOM metadata that exists as well as data within the medical record, and then ultimately create a report that's useful to the clinicians and patients. We've got other data, though, within the Clear Center. As I said, we have a resource core. We've got the consulting services available for stakeholder and patient engagement and to support data analysis. And we've got sort of two flavors of data in the resource core. We've got claims data and we've got primary data that has been collected over the years. For claims data, we share the market scan data with a number of other centers here at UW. It's a large database, 50 million enrollees per year. It's a younger population because they're commercially insured, working adults, and then complementary to that, we have access, as I already said, to the CMS data through the University of Utah. And a couple of different cohorts exist within that CMS data, one focused on patients that have had orthopedic surgery and another back pain. So large data sets, there are certainly limitations with dealing with administrative data like this that one has to be aware of before delving into it, but provides real opportunity. And then we have primary data that we have collected and we as a larger group of investigators from various trials over the years, including both observational as well as randomized trial. Laid Back was one of my first studies. It's probably my proudest accomplishment, is coming up with that acronym in my academic career. And so we have observational cohorts from different integrated health systems, including Kaiser and Harvard Vanguard, Henry Ford. We have randomized trials, which are smaller, but have very deep data within them. And this was a study of spinal stenosis and epidural steroid injection. This is a large pragmatic trial, so over 250,000 participates in that, where we have longitudinal data over 24 months. And we also have pilot funds available for people who are potentially interested in using our data and our resources that we make available once a year. So I've quickly reviewed who we are, what's our goal, what we do, and hopefully piqued your interest for potential future collaborations. So thanks very much for your attention.